All right, so we're going to transition away from cardiac to neurologic monitoring now. So in this question, we have a 10-year-old who's admitted for generalized tonic-clonic seizures and treated with IV lorazepam. The initial cerebral spinal fluid analysis reveals 13 white cells, a normal protein and glucose. Viral and bacterial PCRs are negative. The opening pressure was 12. He continues to be unresponsive with periods of sinus tachycardia without focal neurologic signs. What's the most appropriate next step in the management of this patient? A, repeat lumbar puncture with measurement of the opening pressure. B, external ventricular drain to monitor intracranial pressure and remove excess CSF. C, EEG. D, SSEPs. Or E, nuclear medicine study to assess the cerebral blood flow. Okay, and so the correct answer here is EEG, and I think what this question is trying to get at is you have a patient who essentially is comatose or poorly responsive in the setting of what was previously status, and thus is really at high risk for having ongoing seizure activity, even if it's non-convulsive. So that's what you need to rule out. The LP itself wasn't all that remarkable, so repeating it or measuring ICP doesn't really make sense when it wasn't that bad in the first place. SCPs are really something that we use for severe brain injuries, such as in cardiac arrest, and there's some value for prognosis. The nuclear medicine blood flow study I'm describing is one that we use for brain death, and so that's really not something we're talking about here either, so those don't make sense. Okay, so when should you consider continuous EEG in the PICU? And I say continuous because this particular guideline statement that I have sourced here is really for continuous EEG. The indications for spot EEG are pretty darn similar, although some, would argue that there's a few other indications you might use it for. But generally speaking, if you have a patient who has abnormal mental status and you have any inkling that they might have seizures, whether they have prior seizures that were witnessed, whether they have convulsions that someone's seen, whether they have brain injury that sets them up for seizures, that's a reason to go after it. If you have any kind of acute brain injury with altered mental status, that needs to be high on your differential. So we're talking about strokes, cardiac arrests, meningitis. In cases where you have coma or fluctuating mentation, and again, you don't know why, one of the things on the differential is that you're dealing with seizures. Patients who are deeply sedated, EEG is one way to kind of gauge the depth of sedation and make sure that you're not missing seizures, but also that they're adequately sedated. Patients where you have prior findings on a spot EEG, you might decide to use continuous to make sure you got the seizures under control. Obviously, if you're doing continuous EEG, it gives you the ability to pick up a lot more seizures than, say, a 20 or 30-minute recording will at a time, since you may have missed the seizures in that 30 minutes, but then they happen in the next hour, right? So those are all times to consider EEG in the PICU. It's important to recognize that EEGs do have some progression with time. So here I'm just showing you that some of the different findings, such as the sleep spindles, the architecture, the speed, or so-called frequency of the EEG changes. You're not expected to know how to read EEGs, but this is mostly just to tell you that based on age, what is normal is not going to look the same on the screen as in a newborn versus a 15-year-old. This is just some examples of what are normal sleep and also kind of abnormal spikes. And so I think what's important is that, in this EEG, you have somebody who is, asleep and for the most part looks pretty smooth, but then all of a sudden, whoa, what happens here? And this, you might misinterpret as a seizure, but actually this is just eye-opening, right? And in the case of rapid eye movement sleep, you can see that there's a lot of that, right? Because the eyes are moving rapidly. But then the kind of degree to which these fluctuations look spiky is substantively different than here, where you have epileptiform spikes or polyspikes. And so one of the things one of my mentors used to tell me is if it looks like it wouldn't be comfortable to sit on it, then it probably is pathologic, right? So I wouldn't want to sit on these. I don't think I'd care too much if I sat on these guys, right? And so that's one very crude way to interpret an EEG, but obviously if you're using EEGs, you should have a real epileptologist helping you. Be aware that there are muscle artifacts. So this is just somebody's eyes opening and closing, right? And it, again, can look spiky, but when you have big changes like this, it's probably muscle artifact. In this case, you have a very abnormal EEG in that not only are there these bursts that are kind of pathological looking, but notice there's a lot of suppression, right? So all that normal fluctuation that we saw before is not present, right? And it's important to recognize that things like burst suppression, if they're present constantly, have poor neurologic prognosis associated with them. And so, the suppression ratio is one way to kind of gauge how bad the brain injury is, particularly in processes like cardiac arrest. Now, based on EEG technology, they've developed something called a BIS, which you may be using within your ICU. Certainly a lot of anesthesiologists use the BIS. And what the BIS is essentially a frontal lobe only EEG. So you can see where these sensors are positioned over the frontal lobes. And it's capturing some EEG data and based on it coming up with a value. And the values really correlate to kind of how active or not the EEG is, right? So this is what's showing you what awake versus moderate sedation versus general and then deep anesthesia looks like. And what you can see here is that in somebody who's awake, there's a lot of amplitude and kind of fine fluctuations, and that becomes a much lower frequency here when you get to deep sedation. The machine turns that into a number, and so the BIS index in somebody who's awake is going to be close to 100, and somebody who's really well sedated is down here in kind of the 20, 30, 40 range, right? And so under anesthesia, a lot of times they'll use this when someone's muscle relaxed to make sure they're not waking up under anesthesia. There's pros and cons to this. There's definitely many, many reports in the literature of people who have BISs that are supposedly anesthetized but actually have recall after anesthesia and being paralyzed. And so it's not 100%, but it's better than nothing, right? And if you have a paralyzed patient and you're worried that they're awake under paralysis, this is one way to figure that out. Okay, so wrapping up our neurologic monitoring, we have a 14-year-old who was ejected from an ATV at 30 miles an hour with no helmet. He presents comatose with subdural and intraparenchymal blood. How best should his intracranial pressure be monitored? A parenchymal ICP monitor. B, subdural ICP monitor. C, external ventricular drain. D, serial CT scans. Or E, either A or C, depending on the clinical scenario. Okay, and so the right answer is going to be either an ICP monitor or EVD, depending on the scenario. And so based on the pediatric TBI guidelines, monitoring of ICP has a level 3 recommendation, which basically indicates that there's a low quality of evidence, but nonetheless, they do recommend ICP monitoring. And whether you use a parenchymal ICP monitor or you choose to use an EVD really speaks to whether you plan on draining CSF, which is one way to get the ICP down if it's high. So that's the clinical scenario. Some of the other things here, are potential ways, to measure ICP, but you have to look at the kind of risk-benefit ratio, and with that in mind, EVD may not make sense if there's a high risk of bleeding. On the other hand, because it's going deeper into the brain and into the ventricle. On the other hand, if you really think you're going to be removing fluid, it probably does make sense. Subdural ICP monitors really are not validated, so even though they get used, it's unclear what the means. And then, use of serial CT scans has been tested in adult studies, not in pediatric, so it's not part of the guidelines. This is just to show you some of the different types of ICP monitors. So here you're seeing basically a bolt, which is a parenchymal monitor placed epidurally versus the usual position, which is subarachnoid. So this is the position that is standard and is where it's kind of accepted that this pressure is accurate. A EVD, whether it's tunneled because you have a chronic patient with like a VP shunt and you hook it up to an EVD, or just one that gets put in at bedside, both should end in the ventricle and again gives you a measure of pressure because you're inside this fluid-filled space, but also gives you the ability to drain fluid out. External ventricular devices, in terms of monitoring pressure, very similar to kind of the principles we talked about with an arterial line, depends on where it's zeroed. So in this case, since you're worried about brain pressure, you don't want to zero to the heart, you want to zero to the brain. And so the generally accepted location is called the tragus, which is the essentially where the ear comes into the head. And that's where you want to be focused on for the ICP. That's important for a couple of reasons. First is you want to get accurate values, but also if you're unclamped, so if this is open and all of a sudden the patient sits up and they get way higher than the level of the EVD, what's going to happen is CSF is going to kind of pour out of their brain, right? So you actually want to be really cautious in somebody who's able to move around about leaving their external ventricular drain open because of their drainage. They could overdrain essentially. Indications for EVD placement are kind of summarized here, but include things like hydrocephalus and acute brain injury from a variety of things such as subarachnoid hemorrhage or infections or other issues that lead to high ICP. Now, why do we care about ICP? And the reason is because ICP in the end comes down to CPP, right? So CPP is cerebral perfusion pressure, and it's just a difference between the mean arterial pressure and ICP. And the goal here is you'd like to keep the cerebral perfusion pressure somewhere here in the autoregulatory part of the brain. That way, if the brain needs more blood flow, it can dilate. If it needs less blood flow, it can constrict, and it can maintain constant flow. If, on the other hand, you have a cerebral perfusion pressure that's either too low, then you have a risk for ischemia and the brain can't compensate anymore. Or if you're too high, then you get hyperperfusion or hyperemia, which then can lead to cerebral edema. Now, in a lot of patients who've had acute brain injuries, such as traumatic brain injury patients, their ability to autoregulate is limited or perhaps gone altogether. And so in that situation, if you allow their CPP, they essentially become pressure passive, right? So if you allow their CPP to be really high, they get edema, really low, they get ischemic. So you're trying to guess what is normal and keep it there, right? To avoid either of those ends of the spectrum. Okay, so that is the end of our neuro lecture, and that sums up both hemodynamics and neuromonitoring in the ICU.